I have the pleasure of introducing the speakers. Good afternoon, good morning for some who is joining from other regions, and then good evening for most of us from this region. And then I think we have a very important topic today. I don't think we need to overemphasize the importance of primary healthcare in the health systems in countries, but then to have also the use of digital public goods and to have the ownership of government and then to scale up um, uh, nationwide or subnationwide and then sustaining it over a period of time and then supporting it is also felt as a challenge in some of the places, but we do have very interesting set of speakers, very experienced in implementing it in the states and then also having a pilot initiative in one of the countries. So let me introduce them. And our first speaker will be Dr. Nayan Jani. He's the Additional Director for Family Welfare, National Health Mission, State of Gujarat in India. Dr. Jani is a senior public health official and one of the key state leaders behind Gujarat's digital health transformation under the Technology for Community Health Operations, TECO Plus initiative. As Additional Director for Family Welfare, he has been instrumental in institutionalizing technology-enabled service delivery, particularly for reproductive, maternal, newborn, child, and adolescent health programs. He has led large-scale adoption of TECO Plus across Gujarat's primary health ecosystem, driving improved real-time data visibility, accountability, and follow-up for frontline workers and program managers alike. Under his leadership, the Family Welfare Division has strengthened data-driven decision-making, integrated cold chain and logistics monitoring, and advanced digital reporting aligned with national priorities such as universal immunization program and NQAS-based quality assurance. And our second speaker for the webinar will be Dr. Pinky Jowel. She is an IAS, Indian Administrative Career Officer. She is the Mission Director for National Health Mission, Uttar Pradesh, another state in India. And she is the Secretary for Medical Health and Family Welfare Department, Government of Gujarat. Dr. Pinky Jowel is a medical professional turned distinguished civil servant from 2003 batch of Indian Administrative Service Uttar Pradesh cadre. She currently serves as the Mission Director of the National Health Mission Uttar Pradesh and Secretary for the Department of Medical Health and Family Welfare for the Government of Uttar Pradesh. Her unique blend of medical knowledge and administrative acumen, Dr. Jowel has made significant contributions to public health across various states in India. She is widely respected for her visionary leadership, strategic problem-solving approach, and her pioneering work in public health initiatives and digital innovation in public health care. And our third speaker for the webinar will be Dyna Khuon, University of Health Sciences, Cambodia. She is the Vice Director for the Technical School for Medical Care and Head of Public Health Unit, again at the University of Health Sciences, Cambodia. Dr. Dyna obtained her PhD in epidemiology from the University of California, Los Angeles in 2021. She graduated as a pharmacist from the University of Health Sciences in Phnom Penh, Cambodia, and has a master's degree in nutrition from the country's National Institute of Public Health. Her research interests include HIV, sexually transmitted infections, maternal and child health, mother and child nutrition, communicable and non-communicable diseases. Besides the managerial roles of providing training in public health, she coordinates research with focus on non-communicable diseases, mental health, and maternal and child health. With this introduction, I think we will quickly get to the presentations. And then as you can see that we have the state government officials from two of the large states in India presenting, and then about how their digital health initiatives have been borne by the government, scaled statewide, and then like when compared to the scale of the sub-nations or the states in India, like it can be compared to probably some of the countries in terms of the population as well as geography. And then we will have Dr. Dyna actually sharing the work that the University of Health Sciences is undertaking in Cambodia. Over to you, Dr. Nayan Jani, to start with.
Thank you, sir. Uh, Good afternoon and good evening. Sir, this is the TAKO platform. Already you have talked, and that is a very good, sustained, statewide digital public good for the community health in both ways. It is we are covering the outreach areas, and we are also covering the facilities services also. So this is the platform, TAKO platform for the health improvement started next leg. This is the innovation in Gujarat started in 2017, and it is a very good platform digital model. Um, every maternal and child, not maternal and child, but all the RCH services, and it is the real-time name-based tracking system. We enroll entire in the Gujarat, and both way. It is a mobile platform as well as in the facility base. They can enter in the data of RMNCH plus A. Also, we have added other module in the TAKO as and when required. So I again talk. This is the basic cover all population of the Gujarat is covered under the TAKO platform. Nearly 7 crore population of the Gujarat. All family health survey done in the Gujarat by our frontline worker, and every year it is updated. So entire Gujarat population is covered under the TAKO. So we can use any program for the by this platform, even the NCD, non-communicable disease, and even the other program also. So, sir, this is the scale up module. It is pilot innovation done in 2017, and then it is upgraded all over the 33 districts and 8 corporation of the Gujarat, means rural and urban both. It is in the state government, and under NHM it is integrated state-wise. Already all districts and all corporation covered, and all programs, particularly health program, and again particularly RCH service covered under this. I say this is the life cycle approach. So we have adolescence module, and then after ANC coverage, and then delivery services, and after delivery immunization. So everything is tracked, the name based, who is the left out and who is the dropout. This is the model, and all we there is a flexibility is there. Also, there is a interoperability there, and most importantly, it is the complete government control over the technology. So nothing is concern, means it is not a private data source. It is our in the state government center, that is the data center of the Gujarat government, and it is under the control of the fully control in the state of the Gujarat. So this is the governance and ownership. State is owners all of the data. Government of Gujarat and Family Welfare Department, Health and Family Welfare Department. There is a stewardship, that is a data-driven culture, and there is a strategic partnership. Uh, at pilot, when we have started, then we have included our 108 GB MRI with us for the capacity building. Also, we have a Seva Rural Trust for the that is the NGO, and also the partner private company, that is the RUSoft. We have taken the matlab, IT platform. So immediately we can roll out in entire the state. This is the important as perspective when the implementation is done, then data use and also the data feedback. So regular monitoring, evaluation, and evidence based improvement done in by this platform. Also policy decision, in which area there is a more maternal death, in which area more infant death, where the vaccine preventable disease occur, and where the unimmunized children are there. So also this is the policy decision platform. So you can see the whole chart, that is the data user and feedback, then also the management perspective, and it is also for the policy decision. Good platform used by all over the Gujarat, particularly female health worker, that is the frontline worker, and also by the health facilities. At present, more than 80K, 80,000 active users are there. 100% coverage, not a left any village or any area. So left in this platform. So TECO is integrated entirely in all villages and all the urban area of the Gujarat, and this is the system integrated program. So other module we have integrated, and that is the most important: ABA, RCH service, RBSK, and it is also monitored by our honorable CM office, that is the CM dashboard. So whatever real-time data enter by our data entry operator or the frontline worker, it is monitored by our CM office also. So this is the very important, and also they are giving taking the review and also feedback. So most important is the monitoring, regular review, and also the corrective action by this digital platform in the Gujarat. Very good at present. Everything is on IT platform, and every department wants real-time data, and that is ownership preceded by the sustainability. So launch in 17, and at present it is a good platform in 2025. Right now, already after 8 years, uh, uh, added different module. Even the financial scheme is attached for the beneficiary of the RCH. So I think this is the day by day we have improved a lot, and whatever need of the state is required, we have included in the TECO. So I say this is the again the open source empowerment module. Looking ahead, so this is the Gujarat digital health future. Every program, every family, every individual of the Gujarat is entered in the TECO, and at present already I have mentioned 6.8 crore people of the Gujarat in the TECO platform. Whatever age is there, or male, female, or tribal, non-tribal, urban, rural. So everybody is there, and we can see their RCH service. We can monitor their NCD program, right? So this is the future, or the looking ahead. This is the best digital health future of the Gujarat. Also, this is then next already speaker is there, madam is there from the Uttar Pradesh. So this is the next transport in the Uttar Pradesh, and it is again the same platform used in the Gujarat, that is the TECO, and they also use in the RCH service and name-based tracking system. Both state are going for strengthening health service by this digital platform. In Gujarat, this is TECO, and e-Kavach in the Uttar Pradesh, and this is the comprehensive primary healthcare platform. And definitely, I say we have strengthened it for the data, for the policy decision, and ultimately we achieve also our IMR, our MMR reduce, and even our vaccine preventable disease outbreak is also reduced. So this is the achievement by this digital platform. So thank you, sir, for giving the opportunity. Thank you.
Dr. Nayan Jani, it was very impressive to know the statewide implementation. It's very impressive that you have 100% coverage. And just for the benefit of the other participants who may not be familiar with the term crore, just to highlight like what Dr. Nayan Jani was mentioning, like 6.8 crore means 68 million. So that's the kind of population that is covered. So you can see that the extent of coverage, like probably it could cover the population of maybe a few countries, just to explain you on the scale. Thank you. Over to Dr. Pinky Jowel.
Thank you, Jai Ganesh Shodha Shankaranji from Asia eHealth Information Network, and I thank Asia eHealth Network to give me this opportunity to give presentation about e-Kavach of Uttar Pradesh. And thank you, Dr. Nayan. He has given a brief of his state, and e-Kavach is a kind of an extension, or maybe we started on the same grounds. So this is a comprehensive primary healthcare platform, and we started in 2021, and with an agenda to transform Uttar Pradesh healthcare landscapes through unified digital infrastructure, empowered frontline workers, and ensuring a continuum of healthcare services using the digital method of the moves. Digital interventions are important. Digital interventions are important for a state like Uttar Pradesh. So if you just see the scale of Uttar Pradesh, it's not only one country, it can be a combination of number of countries and maybe more than 4 or 5 countries of big scale. The most populous and the largest state in the country with a population of over 240 million, which is called as a 24 crore in India, and approximately 77% of the rural population, with a very massive, complex public health system and a very different geographical, cultural backgrounds. If we have to divide it, can be 5 different cultural zones. So each zone varies in different way that it reflects, and the people behave, the behavior of the people and the receptivity. Lots of things changes across. Maybe if you move 100 kilometers from one place to the other. So the scale is, we have 18 divisions with 75 districts, 351 tehsils, 827 blocks, and approximately 1,08,164 villages. This is the scale. And we have approximately 32,473 facilities with medical colleges, district hospitals, special hospitals of 143, and community health centers like 975, PSCs 3,747, and sub-centers 27,448. There's a new concept which Government of India has brought in, that's called as an Ayushman Arogya Mandir. These sub-centers are being upgraded to an Ayushman Arogya Mandir, giving a special community health officer. So we have approximately 17,000 Ayushman Arogya Mandirs in the village level at a population of approximately 5,000. So if you have to measure the scale with the number of people we have to work apart from the general population, our public health workforce is approximately, with NHM it is 2.5 lakh almost. It's 22,000 doctors, approximately 33,000 nurses, with 25,000 paramedics, and AeHIN 34,000. 1,67,000 ASHA with 10,000 plus ASHA Sangini, approximately 1,80,000 ASHAs and ASHA Sangini. So they are our frontline workers. So transforming health governance in Uttar Pradesh, the health services in the community, we thought as why we need it, how we have to achieve it, and what are our objectives. So why? The challenges had been, there had been gaps within in infra, in HR, in diagnostics, in drugs, and in delivery systems and services at different levels. So the excess was one of the constraint, infra was another one, and the workforce shortage because of the HR with the regular staff is less, so which was filled with the NHM. Fragmented health data which already existed mostly in manual forms in the service systems. Paper reporting was too much, and it was creating lots of delays and inaccuracies. It is almost 1,000 kilometers stretched from east to west of Uttar Pradesh. So collecting all the data physically, it is a difficult and near to impossible kind of a thing. And the limited data we had with the villages, so that we could not have an effective decision making, and the lack of adequate digital tools we didn't have. So how it had to be achieved is a foundational digital system for a population, facility, registry, HR, drugs, and equipments. We thought we should have a single source of a truth. And then eKavach gave us a single source of a truth, and it's a longitudinal one. And unified community level transaction based systems we wanted, and then it had to be had an ABDM compliant as per the National Government of India's National ABDM mission. We had to implement various HIs to digitize the hospital workflows. The workflow is more important because we may know the processes. If the processes are not rightly made into flow, then it leads to confusion. Then we had lots of different portals with Government of India, and then different departments within the state. So digital integration between the fragmented systems existing. So the theme of it is our frontline workers were the basic targets. So we had to empower them so that we can reach to the common people, and then we can have the real-time tools to get the information data, and then going for a decision making based upon the evidence-based data collection. And that is the basic core of this whole e-Kavach exercise. So what are the objectives of digital transformation of the way we have to go? It is an accountable public system and ecosystem we have to create, ensuring a universal access to the healthcare system through data-driven planning and integrated service delivery, governance, and citizens' participation. The most seems to be very simple thing. The Jan Bhagidari concept, we call it, is a citizens' participation. So it is most important thing, which Dr. Nayan also told, it's a state-led digital health initiative. Most of the other initiatives, they are by some vendor-based, but this is a fully state-owned, and we are in a process to make it as a fully in-house exercise. But that is our future planning, and we are working on it. What it is, it's a unified digital platform designed to transform community health operations, surveillance, and the program integration across Uttar Pradesh. E-commerce serves as a digital backbone for the coordinated healthcare service delivery. Government-led program integration is the most important thing, because we had a different programs. So parallelly, we had different programs vertically within the program. Like in maternal health, we had a different number of schemes, maternal, and then children, and then regarding the adolescent girls. So we had to integrate all. Child nutrition, same way. Child, and then disease surveillance, immunization, very complex and a complicated thing. We need to bring everything into one at one platform. Then it is an open source foundation. Dr. Nayan had already explained to it, and we share the same software, MedPled, and that ensured the flexibility and transparency. Cost effectiveness is one of the major important thing, and the long term sustainability without being scared of the data with somebody else apart from the state, because data is the new gold, people tell, and that it leads to lots of planning based upon that. Comprehensive connectivity is the most important thing. Since many of the areas are dark, and there are places where the internet availability is less, there are forest areas, there are tribal areas, difficult to access. So, seamlessly linking frontline health workers, healthcare facilities, district administration, and the state leadership through a real-time data flow and leading to decision support was the most important thing, especially in a complex state like Uttar Pradesh. So institutionalization by design was another target, because if it is not institutionalized, it goes away with the leader or the person who's leading it to it. So it has been embedded in the administration. Interdepartmental collaboration has been sought after, and ecosystem approach has been taken into, and we have tried to merge with the national platform with the state with different IT sectors of the state administrations. So the key outcome for this was that this institutional design ensures continuity, establishes a clear accountability chain, and it maintains a full state control over the health data and operation, and build a lasting government capacity for the digital health governance. We have brought up into two things, like non-financial as well as data privacy policy into our MOUs with the different partners. So those who are working with us, and this e-Kavach has helped us a lot. So the jump was from silos to the systems. So this was the most important thing, that system level integration for the unified health governance. As you see the program level integration, it is basically one time, if I have to define e-Kavach, it is a one-time population registry. And what does it leads to? Ultimately, enumeration with the ABHA saturation. We have an RCH module in this, we have NCD module, family planning, community surveillance, NDD and anemia, mass drug administration, and stop diarrhea campaign. These are the few of the integrations we have made into it. And a new platform which we have brought is a Mantra app, which is a monitoring, which monitors the maternal and the newborn health, aiming to reduce the maternal mortality, since we were the third last in India, having the worst maternal mortality. MMR was 167. So our target for the last 2 years had been to reduce MMR, NMR, and IMR. So we thought of tracking the delivery in the delivery point itself, and we had created this app. It had been applauded at the national level. And this gives us a real-time service essentials, and we have integrated with our CSR portal of birth and death registration. So all the births are registered directly from this Mantra app itself. Another is the e-rupee voucher. It's an ultrasound facility for all the pregnant women, at least once during the pregnancy, using an e-rupee voucher from the by the empaneled hospitals. So this has been integrated with this, so that we can just revert so many of the health complications before time, and we can just take care of it. And if it is required, we can take them to the higher facility. Unified disease surveillance platform. It is again a unique for the state, and we have integrated this. This gives a real-time disease surveillance. It gives an early warning of any of the outbreaks, and immediately without losing any moment, we just go. Our rapid response teams goes, take effective actions, and it has controlled many of the infectious centers which could have flourished into a big disease area. And then ABDM ecosystem, the ABHA creation, we are the leading in India. And record linkaging along with ABHA, we are using it. And the hospital information system, e-Shushrut and the e-hospital are the two things which gives a real-time disease monitoring, early alerts and the follow-ups. So the core is our basic feat, our base is the frontline workers. And if our frontline workers are made IT enabled and they're strengthened and empowered, they are able to give us the real time information and decision making authority and power to us. If we know that the farthest of my village, which is the border of Nepal or a border of Bihar or a border of some other state or other state, even in the interiors of the forest areas, that we are able to get the real time data using this frontline workers empowerment. So this ABHA, eKavach, this combination of these two have been very, very helpful for us. So ASHA workers, they conduct the comprehensive household surveys, capture the data, they give us health records. Each health record is there, and I'll come to the ABHA IDs generation number later on. And this is an automated targeting. It gives an automatic list of the beneficiaries who are already taken care, who are missed out, so that we can follow up who are all missed out. Then proactive follow-up flows through this only, and there's a digital case reporting and the surveillance has been done. So it's a technology-enabled governance. It's almost all of the things have been covered. I just universal digital enablement hai, comprehensive and structured health intelligence. It records all our different parameters and programs which we mentioned earlier. It is very transparent since it is app based and accountable governance it gives, because once it is logged, we know the data. Interoperable digital systems are there. It's an open API based and ABDM compliant standards are there. Data driven and interoperable governance is there, and citizen centric digital continuum of care from village. Any ASHA, which the data which she feeds in the eKavach, it can be taken care even at the tertiary sector. So if there is a back and forward linkages for transfer, for referral or for any other decision making. For example, now we are going to start with the cancer care centers. So it will be very useful for us because that will be directly linking to the tertiary sector. So this will give us, and the same patient who has been treated maybe somewhere outside can be taken care in the village using this app. So citizen-centric digital continuum, I have already told it, and systemic workflow and intelligent targeting. So this is the most beauty of this app, is it's a systematic workflow, and it gives an intelligent target. We don't have to find out people who all are scattered, whom to focus and who I have to pick and take care of them. So this is the real-time action. These are all theory I was telling, this is an action with the data. If I speak, then it gives some importance to my words. So the total population I told it is 24.18 crores, approximately 25 crore population. Out of this 24 crores, 20 crores, like if you say 204, 207 million population is already enumerated in eKavach. So it means if you see it's 86% of the population is already in the system. Out of, if I take the pregnant women alone, so approximately 67 lakh women are already, they are estimated, we think these are the estimated pregnant women for the whole year coming into the private, going to the private or to the institutional sectors. Out of this, approximately 51, almost 75% are enumerated. And if we take children below 5, 2 crores, 290 lakhs, they're already estimated, and 151, they're already enumerated. Same way, if we go for the CBAC form filled by the ASHA, it's approximately 683 lakhs. It's has to be filled, total number they're updated till now. And with NCT, this is a new thing which we have brought into this one. So approximately 409 lakh population is already been fully screened for either diabetes, hypertension, or cancer of any of 3 types of the cancers. And number of out of these, the number of people examined by MO. Screening is done by the village level, by the CHOs, including at the PSC level. But people, those who are found to be susceptible or suspected cases, they are screened, examined by the MO medical officer. It's approximately 3.16 lakhs. And pregnant women who have been registered for the ANCs is 20 lakhs. Out of, if I can get, 51 lakhs. So VHND session, we track down to the VHND sessions also. So we track each and every ANM's entry or ASHA's entry into the system. So we can just click during the whole process of any campaign or any of the module going on, we just take a look. Oh, this Asha has not entered. This ANM has not entered. She has not entered into the session. We call them and we tell them that your so and so Asha has not entered into it. So and so ANM has not entered. So immediately the system. When I had joined, the session entry was just 36 and 38%. Now it is approximately 85, 86% plus. So symptomatic case found, you can just find out with the UDSP powder is 1.17 lakhs. So they all are geotagged. Almost these ABHAs we have found out is 11 crore plus, they are all geotagged. And electronic health records have already been created for approximately 8 crore population. So this is the scale. And if we are able to generate the electronic health record of the whole population, so anywhere across India, wherever the ABHA is being used, so this system is going to give, at a click of a button, any doctor can have an access to any of the records with the consent of the patient. Because normally we don't carry all the records wherever we go. So this is going to be very useful, because we found eKavach with ABHA is the answer to actual digitization of the all health record. So the number of our health workers using this is 2.35 lakh. Okay, 2.35 lakh population, like our Ashas, Asha Sangini, CHOs and ANMs, they are using it. So eKavach, it integrates all the data, decisions and accountability, all are in the real time. And this is really transforming governance from reactive to the proactive form. So it's an institutional convergence in the true sense, if I have to say. The leadership is the key, political, administrative, till the down the line, till the villages. Government ownership is the key to it, because had it been with some private partner or somebody else, I don't think so we could have that much of a faith, or system could have gone to that level. Institutional reforms and enduring those reforms is the key. Another key, open source enabling long-term value. This gives and we are trying to make it as a permanent in-house technical capacity we are trying to build on there. And the most important thing is it allows a transfer of knowledge. Normally, when we see the different vendors, they go, something is missing. But in-house capacity building and transfer of knowledge had been the key to it. So this is a blueprint. So we are thinking the future governance, what we have to do. The journey is to evolve, guided by lessons learned and the commitment to government-led, open and adaptive digital health ecosystems. That serve the public health. The universal health for all is the motto for us actually. We are on our way to expanding the models. Every time we are trying to get the new Government of India agenda into it, and we are integrating different departments like women and child development and rural development, especially the SHG self-help women self-help groups. We are in a mode to take them into our health motto. Predictive and preventive governance it is giving, since it gives us the prevention form and the alerts to us regarding the disease outbreaks, and gives the different models to it and prevents interventions. The high risk population, especially the HRP, high risk pregnancy, we can just prevent. And we had, let me share that in the SRS data, our MMR has reduced from 167 to 141, and our IMR has also reduced substantially. So we are on a way to using this model, strengthening the data governance, enhancing cybersecurity measures, clearing the data sharing protocols with appropriate privacy safeguards. This is a little challenging thing, but we are on the way to it, and developing in-house, fully institutional capacity for data stewardship and system management. Enabling an equitable care, facilitating data-driven, equitable and efficient healthcare services deliveries that reaches every citizen, especially the most vulnerable and the most inaccessible areas of Uttar Pradesh. The core principle is digital transformation, and it must remain with the government-led, built on an open standards. This should be responsive to the ground realities. So we are keeping changing it depending upon the requirements, and continuously adapted to the emerging public health challenges and opportunities. We hope these learnings support other governments pursuing the open, sustainable digital health systems. The path to institutional delivery, digital health transformation is challenging but achievable with clear vision, sustained commitment, and a focus on building enduring government capacity rather than deploying an isolated technical solutions. Technology is the key that all our Ashas have understood. Technology is the key. The topmost political leadership have understood. We are going to the next stage of incorporating AI into few of our schemes, and then adding with eKavach. So that is our next agenda. And this had been the proper one thing, if I have to convey to you, the educational qualification of few of my ASHA that time earlier had been 8th pass or the 10th pass time. So the whole system is taken by that load of almost 1,80,000 ashas. And these ashas, they are very fluent. If you go in the field, you see they're very fluent in taking care of any of the modules given to them using this e-coach. This is the acceptability of this e-coach platform in Uttar Pradesh. So I am grateful and thankful to all of you for giving me this opportunity to present a little bit about my state and my state team's hard work and work regarding IT integration and transforming health care using the IT platform. Thank you. Thanks for giving me this option. Thank you.
Thank you, Dr. Jowel. It is more than impressive to see the scale in which the state has adopted, scaled, and then, of course, sustaining it. And then due to, since we have very less times left now, let's move to our speaker from Cambodia, Dr. Dyna.
Good morning, good afternoon, and good evening to everyone here. Yes, on behalf of the iMom Care team, I would like to thank the Asia eHealth Information Network for allowing me to have the presentation today. So I am going to present about our project entitled Innovative Mobile Technology for Maternal and Child Health Care in Cambodia. In short, we call it iMom Care, and this is a cluster randomized control trial. This is just the outline of my presentation today. Yeah, so our goal of this project is to develop, implement, and evaluate a digital health intervention to improve the performance of village health support group, we call VHSG, through the support and supervision and increase the MCH, it means the maternal and child health services in the rural Cambodia. And we have several specific objectives. Mainly, we would like to see the gap in maternal and child health care in Cambodia, specifically in the rural area of Cambodia. And we would like to identify the top technology component that could help to improve this gap or to fill out this gap. And with our iMom Care application, we would like to see the improvement in health in maternal and child health care, in primary health care in Cambodia. And also we would like to evaluate the acceptability, feasibility, and usefulness of this application. And one last specific objective is to evaluate the cost effectiveness of the application as well. We have 3 phases in this project. So the first one involves mainly the gap analysis and the application development. Also, after the development of the application, we train the user to use this application. So mainly the user of the application are the village health support group and health center staff. Also, we are trained. I mean the University of Health Sciences technical person are trained by the AgroSoft team, the team who help us with the app development, with the app with how to use the application. And in phase 2, we focus on piloting this application, and then we collect the baseline survey. This is the baseline household survey, which will serve as the baseline to compare with the end line after we implement this project. And after the pilot study, we also conduct a feasibility and acceptability study to see among the user how feasible and how acceptable these applications are. And in phase 3, we focus mainly on the implementation of the application, the iMom Care application. And we will do the feasibility and acceptability study of the application as well at the end of the study. We also collect the end-line survey that, like I said earlier, to compare how this application can improve the maternal and child health care in Cambodia. This slide shows the way how we select our study sites. So in Cambodia, we have 25 provinces. So we could not implement in the whole Cambodia, but we select only 10 provinces. So the 10 provinces are selected based on the MCH index and based somehow on the recommendation from our National Maternal and Child Health Center. In short, we call NMCHC. And we take into account both the index and the recommendation, and then we select the 10 provinces. And that 10 provinces were paired together. So based on the index, we pair the provinces together. So in each pair, we select the OD. So one province we select one OD. OD means operational district. So it's like a district, but it's not an administrative district. It's kind of half operational district. So only one district was selected. And because we would like to focus on only rural Cambodia, so the urban area operational district were excluded from the selection. And one rural area was selected from one provinces, from one province. And within each pair of the province, we randomize one OD in the control arm and another one to be in the intervention arm. So basically, we have 5 OD in the control arm and then 5 and another 5 in the intervention arm. And within each OD, we select 2 health centers. So totally, we have 10 health centers in intervention arm and another 10 in the control arm. And within each health center, we select 10 villages. Yeah, so the villages, the district are the hierarchy of administrative in Cambodia, like how we divide Cambodia, yes. And totally, we have 10 villages in each arm. And within village, we select 2 village health support group to be in our study. And at the same time, health center staff from the selected health center are included in our study as well. And the intervention and control, I talked earlier, it means that in both arms, they provide a standard of care to the population in the coverage area. They receive a refresher training from us, from the expert in maternal and child health from National Maternal and Child Health Center. The only difference is that the intervention arm received the iMom Care application. And I will talk more about what are these applications in my next slide. And the control group does not receive this one, yes. So this is how our application works. So basically, we have 3 triangle, like a triangle. So we have VAG side, we have health center side, and we have our data management side. At the VAG level, we provide them a mobile phone that is equipped with the application, the iMom Care application in that mobile phone. And at the health center, we equip our mobile phone app. We call it the web-based version to the computer or to the laptop that is available at the health center. And the health center staff are trained to use those applications in their own laptop or desktop. And then the data entered by those 2 sides, we are asking into our data management center that is stored at our University of Health Sciences. This picture shows the platform, how our application look. We have 3 features in the form in the application. So the first one, we collect the data. It's like a family health survey and other maternal and child health related indicator in our is our one component of the application. And then we have the remind option, like for example, when we enter all the information of the villager into the application, the village health support group can monitor how many pregnant women in the villages, in each village, how many children need vaccination, stuff like that. So it kind of reminder for them so that they can go directly to their house, or they can call them, telling them that, oh, it's time for you to go to the health center for health checkup, for ANC checkup, or for health vaccination, stuff like that. And in the app itself, we equip with the educational material like video and lesson and quiz. That's all about how to take care of themselves as a mother, as a pregnant woman, and how to take care of their children when they are in the year of 2 years old or younger. Like when they need to seek care, when they need to get vaccination, stuff like that. Yeah, and during the gap analysis, we also in the pilot study, we select one province that is not among the 10 selected provinces. So we select one province, and then within that province, we select one operational district, and then within that one, we select 5 health center, and within each health center, we select 2 VAG and 2 health center staff to pilot our intervention. Yeah, and we also conduct the baseline and endline survey. The baseline survey was already conducted last year, and this is a quantitative household survey that include approximately 2,000 women in the coverage area of the 10 provinces. We interview them about their experiences in health seeking behavior and how they think about the services provided by the health center, the nearby health center, and how about the health expenditure during the last year, and how about the experience in finding services in the have to have the delivery at the health center and so on. We also collect the anthropometry data from the children in that coverage area as well. Inside that, just like mentioned in the method, we also collect the qualitative data, which is about the acceptability and feasibility of the application. We would like to know that this application is helpful, or maybe it's create another burden for them, and how do they find the easiness of using the app, or maybe they find that it is difficult to use. Yeah, so all that are collected during our study, including at the end of pilot study, and we will also do this again at the end of our intervention. So by now we have implemented our application for about 1 year already, and the cost effectiveness evaluation will be conducted at the end of the project. So we aim to estimate the incremental cost and benefit of the intervention of this IMAM care intervention in the intervention provinces compared to the control province. And of course, this cost effectiveness analysis will inform the policymaker about the idea about how they will decide to scale up this intervention into the whole Cambodia. These are the expected outcome. Yes, like said, this application is already in use right now. They are they have sent out for they are rolled out for the intervention since a year ago, and we are midway, and we hope to see that the application will help to increase the maternal and child health services access in rural Cambodia. Not only access, but also the from the provider side as well, that we like to see the provider can provide more services related to maternal and child health. And this is a new model. I think that to advance the digital technology used in primary healthcare in Cambodia. So I can declare, I believe that right now the technology literacy among the user in Cambodia. By user, I mean the village health support group. They are very low. So they start, we train them about how to start the phone, how to turn off, and everything just like from the very, very beginning. That's why I think that this one at least provide an advancing digital technology to the user in Cambodia related to primary health care. Yeah, so finally, we just hope that this will bring to the literature more about e-health in Cambodia as well. And that is it. Next slide, please. It's about the acknowledgement. Yeah, so it's funded by the Bill and Melinda Gates Foundation, and it is implemented by University of Health Sciences with the National University of Singapore and the National Maternal and Child Health Center. That is it. Thank you so much.
Thank you, Dyna, Dr. Dyna, for sharing the work that is happening. I think I can put it as like, of course, we saw 2 states like which have implemented, scaled up extensively statewide, and then the work in Cambodia, like you systematically setting the ground ready for implementation in and scale up. So that's probably how I might summarize, if I am correct. Like you are systematically setting up things in terms of evaluating the feasibility and then also setting the stage for scale up. Since we are already at the top of the hour, like I had some questions for all of you, but I think I think we should take at least one question from the audience. Like I did see one very relevant, helpful question. I think that's from Nirmal Dakal from Nepal. He was asking about the program management part of it. Like I know when we implement a project of this scale, like we are talking about like if the two of the states in India that share the experiences, if we can put together, it's about like almost 300 million population. So when we have such a huge project or scale of operations, like how is this program managed? Like I think he had question about the program management unit. Like what will be the strength of your team? Like what is the kind of team that you have to manage this? This question I will pose to the Dr. Pinky Jowel.
Yeah, we just have one GM, general manager, dealing with the MIS at headquarters, and three people down the line with him. So a team of 4 or 5 people at headquarters. But my other divisional officers and district officers, as well as the GMs, general managers of different divisions, they monitor their programs. Like a maternal health general manager, he monitors his program, and down the line, he takes care that all the data are being fed into the portal. So, team at headquarters is 4 only actually, and we had requested Government of India to give us a little bit more to strengthen our IT sector. So, hopefully, in this PIP, we would like to get some more team members, because right now we are still into the phase of getting the data and collating it and trying to get some information of fake, means not fully this thing, but a faded kind of a decision making. Data analyst are required to get the exact accurate thing. So there are shortfalls, but with a very small team. We don't have a big team. We are 4 at headquarters, and all our ashas are trained in. The training had been done at a very vast scale, physical as well as online. So you can go ahead with a small team also, because it is IT. So you have to give a hands-on training once and then an online training, and continuously for few months, continuous hard work. If you will do it, people will become used to it. Technology is very comfortable nowadays compared to the previous years.
Thank you, Dr. Jowel. This is very helpful and then very impressive to see such a small program management team being able to manage a project of such a large scale. We are also at the top of the hour. If there is any other question that is that can be taken, otherwise we can actually take a group photograph and then we can close. And really would like to thank both. Means I would say just all the 3 speakers. Like it is a very, I could see a very interesting spectrum of I would say uptake and then also implementation. Like one probably at the level of setting up the stage for a larger scale up and the systematic implementation, and then 2 other states which presented have already implemented, and then probably thinking in terms of further integration, further tighter integration, and further improvements. So it's very impressive with that. Like I would like to close as a moderator and then probably handing over to Cha.
Thank you to all our speakers and Sir Jai for moderating the session. To our participants as well for joining us in this webinar. Thank you, everyone.